on acute lower back pain.
Hello, everybody, dear colleagues. It's a real pleasure to be with you today. I'm Sajmal. I'm a rheumatologist and a pain specialist. I'm working in Paris. I'm heading a pain center dedicated to musculoskeletal pain, osteoarthritis, low back pain, fibromyalgia. And today I'd like to share with you my thoughts and also my expertise on the treatment of low back pain, acute low back pain, and I especially would like to speak to you about how multimodal approach can be very useful in acute low back pain, how this concept that is coming from anesthesia is really adapted to the treatment of acute low back pain, and we will is really relevant and really effective in this condition. So here are my disclosures about this presentation, and how, as you can see, low back pain is really a very frequent condition. There are lots of unmet needs in acute and chronic low back pain. And one of these unmet needs is that uh, low back pain, acute low back pain, has multiple pain mechanisms. And at the same time, we should target all these different mechanisms. We should also have a very quick efficacy for acute pain, because this is impacting life, daily life activities. So we should have a treatment that is effective very quickly. Pain is not stable, so we should adapt the treatment to the pain evolution. There are some patients that are more fragile, like elderly patients, so we should treat these patients with treatments that are adapted to this category of pain. The treatment should be tolerable, and there should be very few contraindications, because this is a very frequent condition. So we should treat acute low back pain very easily for the majority of the patients. So as you can see, there are numerous unmet needs, and we will see how some multimodal approach may uh, uh, respond to these unmet needs. First of all, we should remind that there are different mechanisms of pain, and these mechanisms of pain are also found in low back pain. First of all, there is nociceptive pain, that is acute and inflammatory pain, and especially in acute back pain. There are also neuropathic pain mechanism, because pain is mediated by nerves, and when the nerves are, there are alteration of the nerves, neuropathic pain mechanisms are starting. And lastly, there can be also more diffuse, more complex pain, that is nociplastic pain, for example, fibromyalgia. In acute back pain, we will see that mixed pain is very frequent, and there's very frequently a combination of nociceptive and neuropathic pain mechanism. First of all, pain classification is really the first step of the management. And as I mentioned, we should first see if pain is acute, because the mechanisms are different. And if it is acute, do we have nociceptive and non-nociceptive, for example, neuropathic pain mechanism? I will explain you more deeply what we can find in acute back pain. First of all, nociceptive pain is really related to this local modification, and as you can see on this MRI images, these MRI images, demonstrated that there are modification of the disc between the vertebra, but also on the bone. And here you can see bone vertebral inflammation, bone here that describe what we call MODIC 1 score, and this is really related. This is really found in acute back pain. This kind of local inflammation, demonstrating that acute back pain is really a nociceptive pain condition. But it's not only a nociceptive pain condition, because here, as you can see, in patients with back pain, we screen neuropathic pain mechanism applying the DN4 questionnaire. And the DN4 questionnaire was asked to the patient for the pain in the back. This is the orange bars, and also pain in the leg. Here are these bars. And in the back, you can see when there is also only back pain, about 10% of the patients have neuropathic components. So back pain, acute back pain, is not only a nociceptive condition, but we can see in part of the patient a neuropathic component, and the neuropathic component is higher when there is radiation in the leg. Here is class 4 of the low back pain and radiculopathy, but even if there is only back pain, we can find neuropathic component. That means that a treatment that we will use in this patient should target both at the same time nociceptive component and also neuropathic component. Looking at back pain, it's not only a question of mechanism, but it's also a question of duration of the pain. And in back pain, this is very important to consider that there are 3 periods, and in each period, there are some things, some different things that we should consider, and we will see what we call the flags. And for each period, there are different flags, different questions to look in the patient to treat this patient in an adequate manner. The first period is acute back pain, that is lasting less than 6 weeks. Then we have subacute back pain from 6 to 12 weeks. And after 12 weeks, it is considered as a chronic back pain. And in each of these periods, there are specific questions to ask. Acute back pain, we should mainly look at what we call red flags, that is looking at severe back pain related to severe diseases and eliminating the common back pain. Subacute periods, we should look at what we call yellow flags, that are the flags that are the risk factors for chronicity. And in chronic back pain, we should look at the blue flags, that is looking at what is impacting more in chronic back pain and what is we should target when treating chronic back pain. So what are the red flags? It is mainly in acute period. We should look at clinical features that may be associated with the presence of serious condition requiring urgent evaluation and urgent management. That means cancer, infection, fractures, and neurological damages. And this is what is recommended by most of international and national guidelines. Here are the Australian recommendation stating that the presence of red flags pain suggests that the need for further investigation and possible specialist referral as part of the overall strategy. So red flags means that imaging is mandatory, and there's in many cases the requirement of a specialist referral. After the red flags, we will look at more precise pain mechanisms, more precise impact of pain. And here are the two fields that are assessing low back pain in a different manner. If you look at rheumatologists and orthopedic surgeons, they are mainly focused on pain, mobility, function. And here you can see the questionnaires that rheumatologists and orthopedic surgeons are using in back pain assessment. For example, Roland Morris questionnaire, Oswestry, Dallas are the questionnaires looking both at pain and function, but also return to work is very important. And when you look at pain, physicians and neurologists, of course, they are looking at pain and also sensory or motor dysfunction, but they are using different questionnaires looking at the pain mechanism and, for example, looking if there is a neuropathic component by using different questionnaires like the DN4, the pain detect, that are specific questionnaires to screen for neuropathic pain mechanism. So according to the specialties, there are different approaches, but we should say that the best approach is combining these two approaches, looking both at the function, the pain, but also the pain mechanism. And now, when there's a risk of chronicity, when there's a tendency to go to subacute back pain, we should now look at what we call the yellow flags. It means the risk factors for chronicity and complexity, because back pain has a huge impact in daily life activities, in work, in occupation, and it is very important to detect this risk factor for chronicity in patients with acute back pain. For example, we should look at what we call catastrophizing, that are the beliefs that pain is harmful and that there's a risk of severe disabling because of the pain. There's a fear avoidance behavior. That means that patients are not moving, are resting all the day, avoiding activity because of fear of pain, and that is a huge risk for chronicity. Also, depression, anxiety, and social withdrawal are risk factor of chronicity, and passive approach of the patients is also not good for the patient, and because we need active participation of the patient in his treatment. Here are again different tools for these yellow flags, and we have here some questionnaires looking at the fear of movement, the fear avoidance belief questionnaire. These two questionnaires are mainly used in specific centers, like in our pain centers, but also for physicians in rehabilitation. They are very frequently used in back pain patients to see how this kinesiophobia, the fear of movement, should be targeted in the management of these back pain patients. This is the vicious circle of catastrophizing and fear of movement. After back pain, injury of the back, if the patient has catastrophizing, that means that you think that the pain is something that means that it is severe, that there is a risk of disabling, then he will have fear of movement. He will avoid any active approach, any movement, and this vicious circle is increasing disability, disuse, and is leading to depression. And in the management, we should, after injury, treat the patient as soon as possible, as effective as possible, to decrease the pain, to confront the pain with the movement and the activity, and then to help the patient to recover more quickly. So here it's very important to get very effective and very quickly effective treatments to help the patient to confront to the movement and to go to the recovery. So management of low back pain is the management of mixed condition with both, we'll see, nociceptive and neuropathic mechanisms, and also in specific period of time, like the movement-induced or post-exercise pain. There are numerous options to treat back pain. We have analgesics, we have adjuvants or pain modulatory agents like antidepressants, antiepileptics. We have non-pharmacological approaches, rehabilitation, and psychological support. And looking at the drugs, the analgesics that we can use, we have mainly opioids, NSAIDs, steroid injection, topical approaches, and for chronic pain patients or patients that are at risk of chronicity, we will also use antidepressant and anticonvulsants. And that is how we should treat the patient. It's the use of multimodal approach. It's a very interesting approach coming from anesthesiology, and that means that it is a synchronous administration of more than 2 pharmacological agents. And this synchronous administration of of 2 or more pharmacological agents, we will see is very helpful to target different mechanisms at the same time, but also we'll see for other purposes. What is the rationale for multimodal therapy? It's increasing efficacy by using 2 drugs with different mechanisms of action. By that, we can use lower doses of each drug to minimize adverse effects. By acting more effectively and on different mechanisms of action, we may probably prevent chronic pain. We can also target associated symptoms like sleep disturbances, for example, and by using this more effective and for example, less dizziness or less side effects, we may increase adherence of the patient. We should say that multimodal therapy is not polypharmacy. It's really something that is relevant. We should administrate different drugs together, but in a very relevant manner, targeting different mechanisms and with synergistic effect between the 2 drugs. Here are the pharmacological interventions along the nociceptive pain pathway. This is in the periphery when there is an injury, for example, acute back pain. We should use treatments that are acting on the periphery, on the nociceptive component, for example, non-steroidal anti-inflammatory drugs, NSAIDs, but we should also act on the nociceptive pathway in the ascending pathway, but also in the descending modulation. And for example, tramadol is acting on the ascending pathway, is blocking the pain coming from the periphery, but it's also reinforcing descending modulation by its dual effect. So using an NSAID acting more mostly on the periphery, combined with a tramadol that is acting both in the blocking the ascending inputs and reinforcing descending modulation, gives a treatment that has more than at least three types of effect in the nociceptive pain pathway that probably will give more effective treatment and more adapted to the pain pathophysiology with different pain mechanisms. So in back pain, the goals of treatments are to relieve pain, to improve function, also to reduce time away from work. And that's why we should use very effective treatment. Here is a low back pain treatment algorithm that has different parts. The first part is the diagnostic triage, and with using the flags, as we mentioned before. But then there's the treatment, and the treatment with the pharmacological and non-pharmacological option. And you can see that the first step of the treatment in this algorithm is using NSAIDs, weak opioids, and for this is on discussion, muscle relaxation can be also useful in this acute back pain. There are lots of recommendations coming from different countries around the world, and there's a global agreement on the management of back pain in this recommendation using all these kind of treatment. There are numerous treatments for back pain, injection, drugs, surgery, acupuncture, exercise, and all these treatments are used in back pain. And here you can see this network meta-analysis looking at the effect size of all these approaches in back pain. And here are more precisely recommendations coming from the American College of Physicians and they were published in 2017. And the first drug to use in acute back pain is NSAIDs. And if NSAIDs is not enough effective, then we should go to tramadol or duloxetine as a second-line therapy. There are also, of course, Asian treatment guidelines that have been published, some from Philippines, some from Malaysia, and the Malaysians are very recent. And here you can see that in the Philippines, the guidelines recommend paracetamol on a first-line treatment for back pain, but then NSAIDs when paracetamol is ineffective, and the use of opioids, and mainly weak opioids, is also recommended when NSAIDs and paracetamol are not enough effective for acute low back pain. These are the Philippines recommendation. And also here you can see a recommendation from Malaysia, as the Malaysian low back pain management guidelines. And again, the use of NSAIDs if paracetamol is not effective is recommended. And tramadol may be considered if NSAIDs is not effective or contraindicated. So NSAIDs and tramadol are really the main drug to use in acute back pain. Here you can see, as in other society, there is conflicting evidence on the use of muscle relaxant. And for example, in France, it is not now recommended to use muscle relaxant in acute back pain. We will now look at two studies in real life, looking at the use of a fixed combination of tramadol and dexketoprofen. That is in real life very interesting to combine these two treatments because they are acting on different nociceptive pain pathway, and this fixed combination is probably the more relevant combination for the acute back pain, as we have seen, and we'll see in this study compared to other treatment if it's effective and if it gives any additional value. It was compared to the combination of tramadol and dexketoprofen, oral Scudexa, was compared to diclofenac and thiocolchicoside, that is muscle relaxant, in 87 patients with acute back pain visiting emergency department. And the primary endpoint was the pain reduction, but we also looked at side effects and rescue medication. Here you can see, looking at the pain, days 0, day 7, and day 15, there was a decrease of pain in both groups, and there was not real differences between the two groups. But when you look at the rescue medication used in the group of diclofenac and thiocolchicoside, there was an important use of rescue medication, that is paracetamol twice daily, compared to the group of Scudexa, where the use of rescue medication was less than 1/3 of the patient at any day of the study. And looking at the tolerability, here you can see an important side effect in the patient taking diclofenac and thiocolchicoside, that's the heartburn. And there was also some nausea in a group of Scudexa, day 1 and day 5. But as you can see, Scudexa was better tolerated for most of the side effects at day 1 and day 5. Here is another study, an Italian study, also looking at the comparison of oral Scudexa and diclofenac and thiocolchicoside, and in 82 adult patients with low back pain. And again, these patients were followed during 7 days, and you can see that with Scudexa, there's a very rapid and effective effect after 3 days and going to 7 days, while in the other groups there was a decrease, but that was not followed after the first day in this group. And also, when you look at responders, that's the patients that had a significant reduction of more than 30% of pain intensity. Here in the group of tramadol dexketoprofen, you can see that at any time point after 1, 3, and 7 days, the number of responders was significantly higher in the group of tramadol dexketoprofen compared to the other group. And lastly, after that, there was this expert consensus that was published, and I participated to this expert consensus. It was published last year, demonstrating and giving all the details and the reason to use this combination, dexketoprofen and tramadol, fixed combination. And we concluded that it has an important role in pain control in acute exacerbation of back pain, since the two components have proven efficacy, and they also start stating that targeting different sites of action is really appropriate for this mixed pain that is low back pain. So to conclude, I would say that multimodal management of low back pain is really of importance in this condition. We've learned from anesthesiology how to use this multimodal approach to improve analgesic efficacy, to target multi-mechanisms at the same time, and also to use this not only for combining this in a fixed combination, but also, I would say, to go from multimodal approach to multi-professional approach, because here you can see that all the doctors can now use this multimodal approach, not only anesthesiologists, but also GP, orthopedic surgeon, rheumatologist, all the physicians that are involved in this very frequent condition that is back pain. I was really happy